everyone, and welcome to the fourth lecture of the Pearls Lecture Series of 2024. My name is Bilal Hafiz. I am a final year medical student at the University of Melbourne. And today I'm joined by Dr. Casey Parker, who's been with us before in the past with Pearls Lecture Series 2023. And today he's going to be talking about the evolution of ultrasound, which is something we're very excited for. For those that don't know much about Pearls, Pearls is an ultrasound training program that started about almost 2 years ago now. And the program's been to a few places, specifically in the Pacific Islands, but now we're moving into a lot of different places across the Pacific coast and beyond as well. And now it's become this international ultrasound training program, and it's expanding very, very quickly. And a part of our program is to ensure that we have a continuity of our learning after we do on the ground on-hand training as well with our ultrasound. So today, Dr. Casey Parker is going to be talking about the evolution of ultrasound. We're very, very excited. Dr. Parker, before you get started with your talk today, if you could just please share a few thoughts as to how you got started with ultrasound, how you use it in your day-to-day practice as well.
Yeah, thanks, Bilal. Actually, when I talk about the evolution of ultrasound, I'm actually talking about my own personal evolution of ultrasound. And so I started out in ultrasound, or more than 20 years ago now, when I was forced to work in a remote clinic that did a lot of antenatal care. And I used to take a Sonosite C180, which was this really tiny little ultrasound with a screen smaller than an iPhone. We used to put it in a backpack and fly out to clinics and do antenatal ultrasounds with that, and then evolved through the years just by doing lots of training courses, lots of reading, and eventually became more proficient. And over the last 5 years or so, I've actually taken a lot more seriously, and I have undergone a DDU, which is in Australia is a postgraduate diploma in ultrasound, which takes about 2 years to complete to become a comprehensive diagnostic ultrasound provider. So that's been a really long course. And so I think I have a good understanding of what it means to be at the very beginning of your ultrasound journey and all of the things that can happen along the way and how you sort of have to evolve the way you think as you become more proficient with ultrasound.
Amazing. Well, many of our viewers and our attendees are in different zones of their ultrasound journey. So I think this lecture will be very relevant. So please take it away. Thank you.
Thanks. I'm just going to make my slides bigger. So please feel free to throw any comments in the chat. This is going to be pretty much one directional, but I'm more than happy to take questions as we go. So I split my work between a very small town called Broome in the far northwest of WA, which is a beautiful tropical place. And this is a photo that was taken on the beach there in Broome. And we have these cool tidal flats where they have these 70-million-year-old dinosaur footprints actually just right there on the beach, right in front of the cafes and the restaurants along the front there. So it's a pretty amazing thing that you can just walk out your front door and see these fossils just laying there in the sand. So it's a fascinating place, and I recommend getting there if you ever get the chance. There's a large population of people from the South Pacific living in Broome, actually, who are very good at volleyball and beat me soundly whenever we play. So that's a nice connection with the South Pacific. I'm going to talk a bit about the evolution of ultrasound, and I started as a learner, and over the last 5 years or so, I've become more of a teacher of ultrasound. So I've spent a lot of time teaching medical students, junior doctors through POCUS. I also now am one of the coordinators and run the ultrasound training for our DDU, which is our advanced fellows who do diagnostic ultrasound, and that's a 2-year course. So actually, after I finish this lecture today, I'm going to be running a Zoom call teaching all about abdominal ultrasound to our candidates that are sitting our exams coming up in August. So that's a much more comprehensive ultrasound, but the principles still apply. And I think this slide's sort of something that I try and teach all of my learners is that there's 3 things you need to be able to be a good sonographer. And number 1 is you've got to have the hand skills. So you have to be able to take the probe, move the probe, put the probe in the right spot, adjust the pictures, and get the pictures looking just right. Because if you can't see what it is that you need to see in order to make the diagnosis, then you won't get there. So you really need to learn that hands-on, and that's great that you guys are having hands-on courses run by Pearls, and I'm sure you spend a lot of time learning on your own and honing those skills to make your hand skills better. A lot of it's about just practice and repetition. So hands is really important. Training your eyes for ultrasound is much harder to do, and that requires you to see lots and lots of images of normals and abnormals. And so scanning as much as you can, spending a lot of time looking at other people's images. And I understand that the PELS lecture of Jono and the PELS committee are now running image review sessions where you can go through a bank of images and look at your own images and have experts look at them as well. So training your eyes is really important, and the best way to do that is just by looking at lots and lots of images. And the third prong of this ultrasound learning is about training your brain. You need to train your brain in two ways. One, you need to be able to know what things are so that you can recognize them, because you could get a perfectly acquired picture of a liver and swipe right through it and have a great picture on the screen. But if you don't know what a certain pathology looks like, you won't actually recognize it. You can't see what you don't know. So training your brain to see something is really important as well. And I think the other thing that is really pertinent, particularly for people working in remote places like Broome or the South Pacific Islands, is that you need to understand what you need to do with that information once you acquire it. And so it's very easy to get a great picture and show some pathology, but you need to have a good idea as to what that actually means and what it means in your context specifically. So last year I gave a lecture on scrotal ultrasound. We talked a lot about torsion. And obviously, torsion means different things depending whether you're in a major tertiary hospital, where there's a surgeon or a urologist right next door, versus on a small island that may be many hours or days even away from that resource. So knowing what to do with that information is really important. So hands, eyes, and brain. If you do nothing else, I try and break your ultrasound journey down into those three things. I'm going to show some cases which hopefully sort of show how this is really relevant to learning and how you can be more active in your learning process as well as you go through this learning journey. Quick quiz. If I were to tell you quiz, I want you all to mentally work out what the answer to this quiz is. So I'm going to tell you about an animal that has 4 legs. It can run really fast. It eats grass, and it has a mane on its neck. Now, most of you should be thinking, well, that's a horse. But if I show you this picture, then you obviously are thinking that's a zebra. And a lot of what we do in ultrasound is this. It's about recognizing patterns. It's about taking information, passing it through the filter of our brain and going, aha, that's what it is because I've seen this before. So a lot of that hands is about getting the right picture on the screen, and eyes is about recognizing patterns. And then, of course, the brain is knowing what to do when you see that pattern. So this was the basic evolution of ultrasound skills for me. Is I'm a GP anaesthetist, so I do a lot of procedural stuff. I put in a lot of lines, do a lot of peripheral nerve blocks, those sorts of things. So a lot of my early ultrasound education was around procedures. So learning how to put a needle or a sharp thing into a body cavity or around some anatomy to get a block or get a line in. I think that's a really fundamental ultrasound skill, and that something that anyone that is using ultrasound should learn to use early on in their career, because it's probably the highest yield in terms of making your patients' lives better, in terms of safer, having more timely access to pain relief and things like that as well. So I think procedural ultrasound is really important. We teach a lot of POCUS in the Western world, so a lot of binary decision-making ultrasounds and things like the FAST exam is a classical example of this, where we tell people to say, yes, there is, or no, there isn't a pathology there. There is blood or there isn't blood. There is a pregnancy or there isn't a pregnancy. And so it's all about sorting out the goats from the sheep. It's a very simple way of thinking about ultrasound, and certainly something that can be really useful in terms of learning those skills. And then as you get more advanced, you need to go more into what we call protocol-based ultrasound. And this is what I did in the last 5 years, is I went from someone that did POCUS, where I just put the probe on and say, yes, that's there, or no, it isn't, to more of a protocol base, where if I have someone with right-sided abdominal pain, I can't just put it on and go, oh yes, there's an appendix, or no, there isn't. I have to go through all the organs in the belly and look at all of them in a sort of systematic manner to make sure I'm not missing anything. So that's more protocol based. That's sort of following the textbook and looking at everything. And then eventually you get to the point where you're a more comprehensive ultrasound person. So you can see everything that happens and you're actually making decisions on the fly. You're clinically integrating what's actually happening on your protocol into what the clinical picture with the patient is, and making a really comprehensive sort of plan with your ultrasound. But that's a real gradient of skills. And to be a comprehensive sonographer, you need to have all three of those hands, eyes, and brain skills going at once. Okay, I'll show you a few cases. So this is a classic broom case. So this is a young man who unfortunately was beaten by someone who he knew quite well and has taken a few kicks to the ribs and to the abdomen. And if you're a POCUS person and you can do a fast exam, this is very simple. So this is a transverse view of the pelvis. There's obviously a few bowel loops floating in there. You can see the iliac vessels on the side, and there's lots of blood. So this is lots and lots of blood. So this whole pelvic bowl is full of gray, swirly blood. And so that's clearly a true positive on a fast exam. So that should make you very worried straight away. And that's what POCUS does for you. It means that you can take this young person that had relatively normal looking obs and escalate them straight from, oh, he's a guy that's been kicked in the ribs to this is someone who's seriously unwell, and you can expedite their care or get them to what they need to be straight away. A surgeon probably, or a CAT scanner if there's one available. However, once you've done a bit more protocol learning, you can actually be a little bit more inquisitive, and you can start looking around. You can go, well, if I look at his spleen, I can actually see he's got a big splenic hematoma there. So that's probably where this blood is coming from. So you can be a little bit more nuanced. So when you're speaking to the surgeon or the retrieval team or whoever it may be over the phone, you can say, well, this is what I think is going on. It doesn't actually help the patient that much, but it's certainly more satisfying from a doctor point of view if you can see what's happening. And then once you get even better, this is the same patient. And in our local surgery up in Broome, we have a surgeon who can take this guy to theatre and oversew his, take out his spleen or tie off some vessels. But the thing that I noticed about this scan as I was scanning through this patient is once again, this is a right upper quadrant view. There's once again a heap of blood in Morrison's pouch. But the thing that maybe most people that would do POCUS wouldn't appreciate is that there's also blood in the perinephric space. So if you look at this space here behind the peritoneum, just next to the inferior tip of the kidney, there's also blood in that space. And that's really useful information if you don't have a CAT scan, because now you're taking a patient that's got an intraperitoneal blood source and you're saying to the surgeon, well, actually, there's blood in the retroperitoneal space as well. So we need to think about what else could be going on here with this patient. So it just gives you a bit more information and can be really useful if you don't have a CAT scan, particularly, which we often don't. All right, I'll show you another example now. This is pretty typical gallbladder case. So I don't think there's any doubt here that this patient has gallstones. So there's a beautiful long picture through the gallbladder. You can see a nice echogenic stone with a nice shadow behind it. So no doubt about it, this patient has gallstones. Now, that's not a very hard picture to take. You don't need a lot of hand skills to get that picture. You don't need a lot of eye skills to see it because it's pretty obvious. But you do need to have the brain skills to think if this person's got abdominal pain and they've got a single gallstone that's sort of floating up around the fundus, is that really the cause of their symptoms? Is that why they're in pain? And one of the things that I've noticed in my journey is when to recognize pathology that's there, but is an incidental to what's actually going on. And that is a lot harder to do than just taking pictures because you have to stop and think, is this the cause of the problem? And that's a harder thing to do, I think, in ultrasound than just pointing and shooting and saying, there's a gallstone there, that must be the cause, because you may be doing that patient an injustice and missing the more important pathology. I'll show you another gallbladder clip here if I can get it to play. There we go. And this one's a bit trickier. So if you watch this clip go through, once again, it's a gallbladder picture. Instead of a nice simple stone though, we're seeing this whole ball of what's called sludge or tumefactive sludge, and there's a few stones up there in the fundus. But if you watch really carefully, if we play this clip through again, there is actually a big juicy stone sitting right in the neck of the gallbladder down here with a nice shadow behind it. If I play that through again, just there, you can see that stone sitting right there in the neck of the gallbladder. And it's very simple when you're learning ultrasound to look at this bit of the organ and say, oh, that looks okay, or it's got a bit of sludge in it. But if you see this, then you've got a slam dunk diagnosis. You know that this is the problem. This is what's causing the patient's symptoms. And this is about being really disciplined and about not just taking one picture, but looking through a whole organ, looking from top to bottom, from left to right, from inferior to posterior, and just making sure you're seeing the whole thing in 3D. And then you can say, yes, I've seen it all, and it's normal, abnormal, or now I know exactly what's going on. So it's something I learned the hard way over many misses where I would look at the fundus and I'd look at something else, but I wouldn't actually see the bit that I really needed to see. So it's a great case to point that out. And then here's another gallbladder. Once again, transverse diameter. This is a really tricky one to see. And I'm following a protocol now. I'm thinking, well, that's a dilated gallbladder, so there must be something going on. Then you start realizing, oh, there is a stone there, which maybe I wouldn't have seen if I hadn't looked at that first. And then when you look a bit further, you go, oh, there's a bit of pus. And then as you get even better, you start to see things like small perforations in the gallbladder wall. And this is not something that I would have ever been able to see 5 or 10 years ago. But as I get more practice and I've seen hundreds of these, I can start making these more subtle, nuanced diagnoses. So I think it's something I wish someone had told me many years ago, that as you go through this, it gets easier and easier with time as you get more and more practice, and you can make these more subtle calls, which is very rewarding and also can be very good for your patients, particularly if you're in the middle of nowhere. I think probably one of the hardest things to learn if you're doing point of care ultrasound is this one. And this is about looking for the common bile duct. And we talk a lot about looking for gallstones, and that's pretty easy, but finding gallstones in the common bile duct is really tricky. And if you watch this video through, you can see that there's dilation of the biliary tree inside the liver, and you can see a big CBD. But this would be very easy to miss this stone sitting here in the gall, in the common bile duct. And obviously that makes a big difference for this patient because they need an urgent intervention to fix that up. That may not be available where you are. And in Broome, particularly, I'm about 2,000 kilometers away from someone that can go in and retrieve this stone and fix up the patient's problem. So being able to pick this is really important. But sometimes you don't see it, and you need to go back to that brain thing that we talked about before. And if you're seeing a big CBD and you're seeing lots of dilatation and the patient looks unwell, then that's when you need to put the probe down and use your brain and go, this patient needs to get to somewhere where they can get this sorted out, and not have too much pride in not being able to see everything on ultrasound, because the stats would show that when we miss these about 1 in 5, and that's a humbling thing to think that even the experts miss these a good proportion of the time. And I'll just play one more through. And the reason I put this case in is not because it's super important for you to recognize this, but sometimes you just look at an ultrasound and you go, I don't know what's going on here. And this is the same patient as this one. So play this clip through. There's a gallbladder. It's got lots of that sludgy looking stuff in it. But when you put the color flow on, you realize that this is actually a really nasty tumor. So this is a cholangiocarcinoma. And I don't think it's important that you, as a point of care provider or someone that's starting out, can make these diagnoses and can, look at all the subtleties of what's going on in this situation. But I do think it is really important that when you're learning, that you recognize when to say, this is really abnormal and I need to get more information. I can't help this patient anymore by doing a bedside ultrasound. I need to move on to the next step. And we see this a lot in point of care. The more you look, the more stuff you find, and the more stuff you find, the more you need to know what to do with it. So having the cognitive ability to sort of say, I'm going to stop, I'm just going to think about this, and I'm going to decide what I'm going to do with this, because sometimes it's not always what you think. A couple of interesting cases which sort of changed the way I thought about things. So this is a fascinating case of a man who was blind. He had terrible cataracts and he couldn't see, and he fell over and hit his head on the side of the bathtub in his bathroom. And then when he got up off the floor, he realized that he could see out of his eye. And then he came to the emergency department saying, I can see, which it's not something I see very often in my emergency department, people complaining that they can see. But we have a lot of bad cataract disease in the northwest part of Australia. So this man had actually dislocated his lens, which was previously obscuring his vision, and pushed it off to the side of his eyeball when it hit his head. And all of a sudden he could see again. So it was more of an interesting scan that we don't often see that very often, people complaining of improved vision presenting to the emergency department. This is what we see more of in our diabetic population, in our Aboriginal people in the north part of Australia. So this is a really good ultrasound because it shows you a very clear retinal detachment. So this is the retina. You can actually see the blood vessels coming out of the optic nerve going up into the retina. And so if you see this in our part of the world, this is someone that needs to get to an ophthalmologist as soon as possible. But I'm a long way from ophthalmology services. So this patient may have to travel on a plane for several hours to go and see an ophthalmologist. And if you see this, I think, yeah, that is something that's very bad. This patient's got sudden visual loss, and this is potentially something that could be saved. However, when I first started out looking at eyeballs, I saw a lot of this, which is this sort of floating membrane sitting in the back of the eyeball there. So this sort of, we call this socks in the washing machine. So it's this little membrane floating around in the back of the eyeball. And this is very easy if you get your settings wrong on your ultrasound machine to mistake it for the previous one. This is a thick white band that's fixed at the back here. Whereas if you look at this one, it can look very similar if you get this thick band, but this is finer and it's floating around. It's not really fixed anywhere. So this is the vitreous detachment. And this doesn't need to go to see the ophthalmologist straight away. But when I was learning about eyeballs 5-10 years ago, I found it really difficult to sort of make that call. Which one needs to see the eye doctor right away and which one can wait a couple of weeks or a month or whatever until they can get to see someone. How urgent is this in triaging? And so I had to really train my brain over a course of a number of patients to recognize what was super important and what could wait a little while. So it takes a while, and having the right settings on your machine and having the right decisions in your brain are really important when you're making those calls. We have a lot of people that live in very remote communities in the north part of Australia, and this is an excellent case which sort of highlights some of the problems we have. So this is a young woman, she's only about 30, who had a hemoglobin of 21. So one of the lowest hemoglobins I've seen in a person that's walking around talking to me, and otherwise look reasonably well. So she'd presented to the emergency department complaining of several months of really heavy menstrual bleeding, so menorrhagia. And it was thought that that was the cause of her hemoglobin of 21. And so the gynecologist came to me and said, look, we need to take this young woman to theatre. We need to do something to stop her menstrual bleeding so that we can give her some transfusion and fix up her hemoglobin and get her all better again. But they said, do you mind having a look and just seeing what her uterus looks like? So I put the probe on. Sorry, it's not a very good picture, but scanning through the pelvis, just looking from top to bottom. And she obviously has a very big, bulky looking uterus. So I recognize that. And I think 5 years ago, I would have stopped there and said, yeah, she's got a big, bulky looking uterus. She's probably got fibroid disease or some other problems with the uterus. She needs to go to theatre and have the gynecologist sort this out. But what I noticed, because I had done a bit more training, is as you scan through this, I'll just see if I can stop it in just the right place. If you look up at the top here, there's a loop of bowel, and it's outlined by fluid all around. So she's actually got ascites as well, which made me stop and think, that doesn't make sense. Why would a young woman who's been bleeding heavily and is severely anemic have ascites? And so because I work in Broome and we have a very high rate of rheumatic heart disease, I decided to have a look at her heart. And this is a young woman. She's hemoglobin of 21. And you can see her heart's beating away there. And then maybe 5 years ago, I would have looked at that echo and gone, it's probably not ideal. It's not performing as much as I would have liked it to, but I wouldn't have been brave enough to then do this, which is put color flow on and have a look, because I wasn't really taught how to do this. And then as I learned more and more, I started expanding my skill set, not because I really wanted to be really good at echo, but because I work in a hospital that has a lot of rheumatic fever. This became a skill that was really useful. I'd have to put these patients off to sleep or perform a cesarean on them. It's really good to know about this before you dive in the deep end and start doing operations and giving anesthetic agents. So this woman's got a combination of aortic regurgitation and mitral regurgitation, probably of moderate severity. So this is someone who I'm starting to get more and more worried about, A, because she's got a very low hemoglobin, her heart's not working very well, and also because she needs to have an operation. So then the question becomes, is it safe to do an operation on this patient? And here's that apical four-chamber view showing that for a young woman with a low hemoglobin, this is a very inappropriately hypokinetic heart. So her heart's not doing much at all. I would expect it to be much more hyperkinetic if she's that unwell. So I started realizing that this was part of a chronic process, not something that had just happened overnight, but something that had gone on for a while. And so we elected not to take this young woman to theatre, but instead to transfer her to a major hospital where she could get cardiac services as well as gynecology services all sorted out at once. This is another interesting echo case, and I think this goes to show how as you get better at doing ultrasound, sometimes you learn how to say no, and that's why I'm showing you this case. So this is a young man who was had end-stage renal failure and was on dialysis, but he had had a lot of social problems and unfortunately hadn't been able to attend much of his dialysis. So in the last 3 or 4 months, he'd only been to maybe one of three or 1 in 4 out of his dialysis sessions, and he's becoming increasingly uremic and in heart failure. And his kidney function obviously was pretty much non-existent, but he came in feeling very short of breath, and he had the usual things where he got some dialysis and he got some non-invasive ventilation, some high flow oxygen, but he just wasn't really getting better the way patients like this normally do. So we had a look at his heart, and as you can see from his echo, he's got a very large pericardial effusion, which has got all these sort of fibrin strands floating in it. And this is very typical for uremic pericarditis. So he had a very high urea, a 45 or something like that. And he had this very uremic looking pericarditis. So then the next question is, I'm a long way from a heart doctor. And the question is, should we do something about this? Should we take a needle and drain this pericardial effusion? It might help his cardiac function. It might make him feel better. It might help with the shortness of breath. And that's a really difficult question, because I think if I'd seen this a number of years ago, I probably would have said, well, it's a really big effusion. His heart's not doing that well. I probably would go ahead and do something. But now that I've done a bit more work, I actually could do a comprehensive Doppler on this man and see that it actually wasn't causing him any problems. This pericardial effusion wasn't causing any signs of ventricular interdependence. It wasn't causing any tamponade sonographically. And so we elected not to do anything about it. And that's probably a harder decision to make sometimes when you're looking after a really sick patient, is deciding not to do something that previously you thought maybe you would have done. So it's interesting, as you get more skills, you sometimes do less, which is fascinating in my mind. Another skill that I've learned over the years is about doing soft tissue ultrasound. We have some very bad diabetes in our part of the world, and we have a lot of patients that present with bad diabetic foot infections. And so this is very common. I see this in the emergency department pretty much every day. Someone that comes through with a heel or a sore on the sole of their foot, which is infected and inflamed. And sometimes they come in looking quite septic, and we're never quite sure, who do we need to rush to theatre right away? Who can we treat with antibiotics, and who can wait till the next day? Or when do we need to actually drain that pus to make this patient better? And so this is a case of a man that had sore on the ball of his foot. As you can see, here's the bit of jelly, but you can see the skin. You can see there is a small collection there just under the skin, just above the fascial plane. And then I took a little video loop. If you just follow this video loop, you can actually see a tract of pus coming through from the surface of the skin down into this collection. But the thing that's really scary on this picture, which is very subtle and I think is easy to miss if you're learning ultrasound, are all these little white things just sitting in the collection. So within the collection, there's all these little white flecks, and this is actually gas in the tissues. So this is a necrotizing skin infection, and this is one that you definitely don't want to leave till tomorrow morning. So it makes my job easier, because I've trained my eye to look for this over a number of years. So when I scan people's feet now, I'm very proactively looking for these bubbles of gas within the tissue, because that's the group of patients that I think will benefit from going to theatre straight away and having that drained, because they don't tend to do well if they don't get an operation immediately. A couple more cases just to demonstrate. Once again, another gallbladder. I seem to be obsessed with gallbladders today. So this is a gallbladder that I was shown by one of my junior trainee doctors, and they'd done my course, and they'd come along and said, oh, I found a thick-walled gallbladder. This person's got cholecystitis. And once again, if you look at this gallbladder, you say, yeah, that looks thick-walled. There's lots of fluid around it, but there's no stones in it. And it sort of doesn't make sense. And once you've looked at a lot of inflamed gallbladders, you realize it's very unusual to see this very symmetrical inflammatory fluid all the way around. Usually people with cholecystitis have like sort of weird looking, irregular, shaggy looking gallbladders. They don't have this nice symmetrical rim. And so this made me realize that this wasn't a gallbladder problem. So once again, we picked up the echo probe and we had a look at this patient's heart. sorry, that picture's a little bit skew with, but really, really terrible left ventricular function. So this patient was in fulminant heart failure. So that fluid around the gallbladder was actually just essentially liver fluid leaking through from the liver from the patient's heart failure. So a very bad mitral valve lesion there as well with dilated cardiomyopathy. So once again, makes you realize this is someone that would have done very badly if they went for an operation in Broome. Sorry, go back to the full screen. Probably the most utile thing I do with ultrasound in my emergency department, where I only have access to x-rays about half the time, is in looking for pneumonia. And when I first started doing chest ultrasounds in children, looking for pneumonias or infections, I wasn't really sure what to make of it all until these weird looking patterns. So if you know a little bit about lung ultrasound, you know that these sharp lines coming off the pleura going straight down are called B lines. And on the right of screen here, we have a kidney, which is a normal kidney. And on the left-hand side of the screen, we have a large area of consolidation within the lung. And it took me a while to work out exactly when to call something pneumonia and when to call it, well, this is just a kid with a bit of mucus in their chest, or a viral looking pattern or pneumonitis. But as I got more and more adept at this over the years, I've actually gotten to the point now where I feel confident that I can look at kids like this, look at the clinical picture, look at their ultrasound, and decide who is really going to get sick and who maybe just has a case of the flu and can go home and probably do okay. So we do this pretty routinely now, and to the point where most of the pediatricians that I work with now are quite happy to accept lung ultrasound as a diagnosis rather than relying on X-ray, because this child had an X-ray. That's his lung in cross section. You can actually see the air bronchograms going through there. But that's his chest X-ray, and it's sure he's got pneumonia, but that took a day before we could get that X-ray. And we sort of knew what to do with this kid the day before because we'd seen the pictures. We knew what it was going to look like. And often lung ultrasound is better than chest X-ray in picking pneumonias, I find, once I've done lots of them. So this is one of those modalities where I actually prefer ultrasound to the more traditional chest X-ray. And that comes to the end of my case, but I just thought I'd throw one case in there if there's any brave souls that want to have a guess as to what this is. So this is a picture of a mass in a young woman's pelvis. And this is all about pattern recognition and being able to train your brain to just see things. Because when I see this now, I know exactly what it is before I've even put the probe down. But I think 3 or 4 years ago, before I'd gone through that process of looking at thousands of ultrasounds and reading Radiopedia and other websites like that, I wouldn't have been able to pick this. I would have just been confused by what I was seeing on the screen. So I don't know if anyone, that's my last picture. Bilal, does anyone have any comments or questions, or anyone want to have a stab at that one before I give the answer away? Can't see anyone putting their hand up. So I'll just yell it out anyway. Oh, there's someone's in the chat there. Ah, Joe knows what it is, but I think she's got the advantage of having looked at thousands and thousands of pelvises. So so this is a dermoid or a teratoma, and it's a classic picture of a teratoma in that you've got this is the fat plug here with the shadow behind it. And this is what we call the dot and dash sign within the cyst, which is usually hair that's grown within this thing, within this tumor. So this is a benign tumor, which is actually really common. And I think I probably scanned hundreds of women for early pregnancy and for other problems throughout the years and never saw one of these. And then once I learned how to find them and what they look like, I see them all the time. And it's something that it's probably not the end of the world if you miss it when you're doing point of care ultrasound, but it's amazing how much information there is when you start looking with ultrasound. And that's just part of that journey is being able to recognize things and being able to know what to do with them. So training your brain and your eyes is just as important as training your hands. And so I really recommend that you take the opportunity to do the image review process with the mentors that you have, because that's a really important part of ultrasound, is learning to train your eyes and know what to do with those cases when you do find them, because learning the hand skills is one thing, but learning the other stuff is probably equally as important.